Yeah, so welcome to interventional session. I'm Dr. SHARATH Reddy, interventional cardiologist, Medicover Hospitals, Hyderabad. Today's case is an interesting case, away from our routine cases of coronary CTOs and complex PCI or chip PCI. This is a case of abdominal aortic aneurysm in a small aorta. So this patient is a 69-year-old male with coronary artery disease, status post PCI2 right coronary artery in 2003, and post bypass with LIMA2 LAD and SVG2 RCA, but evaluated in 2017, that is 10 years later, and both grafts were occluded, and now presented with an abdominal pain, and in subsequent investigations it was diagnosed that there is an abdominal aortic aneurysm, for which he came to therapy for us. He has mild LV dysfunction and normal sinus rhythm. These are the comorbidities: diabetic, rheumatoid arthritis, and disease modifying drugs, and all treated pulmonary COX 4 years before. Obviously high risk for open surgery in view of post CABG, failed grafts, mild LV dysfunction, and rheumatoid arthritis with disease modifying drugs. Okay, so we'll come to CT analysis in this patient. So you can see is abdominal aorta below the renal artery was just around 13.4 millimeters, so it's less than 14 millimeters, which is small actually. Anything less than 18 millimeters is considered small aorta. And you can also see at the aneurysm site it's like 4.5 centimeters, so it's less than 5 centimeters. But the issue is here 4.5 centimeters in a 14 millimeters aorta, so that is clearly more than 3.5 times the size of the aorta. So that's the reason we decided to treat this aneurysm, and also patient was symptomatic. Next is diameters of iliofemorals. On right iliac artery was around 8.6 millimeters, and the smallest size was in external iliac artery on the right side, which was around 6 millimeters, and on left side it was 6.6 millimeters, and iliacs on left was almost like 7.9 millimeters. So right external iliac 6 millimeters was the smallest size available, smallest size, so which clearly says through which we can take only 23 millimeters graft. In this case, since the aorta size is only 14 mm and the smallest graft available was 23 millimeters, so we decided to go ahead with 23 millimeters graft. And I can see here, so this neck size is you have a good landing zone here, nearly 3.7 centimeters, and these are the lengths up to bifurcation. So one blessing in disguise in this case was aneurysm was extending up to bifurcation, so that's a very key in this case, because when you're taking aorto bifurcation aortic graft, so your bifurcation segment of graft would sit here, and if the aorta below the aneurysm or just above the bifurcation was 14 millimeters, then the expansion of both extensions, ipsilateral and contralateral gates becomes a big issue, and that's the reason in this case this was a blessing in disguise, aneurysm extending up to bifurcation. And second point here is, so when we are deploying the graft, your the bifurcation of the graft portion should start, in the aneurysm, and your left iliac, the contragate should open above the aneurysm, immediately above the bifurcation. So that's very important in this case. And yeah, I mean, we can, so keeping that in mind, we decided to go ahead with 23 to 10 main graft, so wherein we can fit iliac graft, within the aneurysm, followed by, left extension. So that was the plan. Arrow.
Space.
Okay, so right accessory renal artery was the lowest here. So yeah, that's what a landmark. We did a coronary angiogram, so you can see, mainly because of his previous coronary state, right coronary angiogram was normal. Right coronary was totally occluded in the middle, and distal vessel was completely small and with a little retrograde filling, and in fact his territory of right coronary artery was bit non-viable, and also LAD was totally occluded, but we analyzed LAD both in CT as well as in angiogram. It was not graftable, so that's why we left it. And his femoral artery is on right side, so we took right side as a main graft insertion. So femoral artery was 6 mm, as already I discussed. So we did pre-closure with two devices, ProGlide devices, followed by left femoral artery puncture, so where we inserted one ProGlide on left side. So since left side is only 14 French device, so one ProGlide should be enough, but right side is like a 18 French device. Probably second ProGlide would help in case of any problem. So at this aortogram, you can see the aneurysm. There's a huge aneurysm, and yeah, you can also appreciate aorta size is quite small. And after the analysis, we took main graft. As I mentioned already, it is 23 to 10 tapering, 145 centimeters length, endurant graft. And we deployed endurant graft, and key here is the left iliac, the contragate. So the contragate markers should be within the aneurysm. That is very important. So that's what we made sure. So two contragate markers were positioned into the aneurysm, and then we deployed. So we can see the deployment of the graft. So now this is a first marker of contralateral gate. So, and we're coming down, and that's a second marker of contragate. Both are within the aneurysm, and now you can see your contragate is open completely and it is sitting within the aneurysm. So that's key for full expansion of both iliac extensions and the bifurcated portion of the graft. So and now we released the nose cone, followed by rewiring of contragate. So this is a nose cone release, and then we removed pigtail, and then we rewired contragate with a JR catheter. So this is JR catheter with the thermo wire, and we checked in both the views as well as with a contrast to confirm the position inside the stent graft. And then we took an iliac extension. We sized the iliac extension. This is sizing of iliac extension. So we took 90 millimeters 16:10 tapering device based on Mocker pigtail assessment. So now we are deploying stent graft left iliac extension after overlapping both the markers. So once left extension is deployed, once left extension was deployed, we deployed even right main graft completely, and then we pulled, after recapturing nose cone, we pulled the main graft sheath out, followed by placement of the 14 French sheath to the right punctured side for subsequent ballooning, and left side also we removed and placed a sheath. So this is aortogram mainly to rule out type 1 endoleak before dilating. You can see right iliac position there is a narrowing in the graft was not extended properly. That is exactly at the site of the bifurcation. So we decided to do a balloon. So we took two 10 millimeters peripheral balloons and deployed simultaneously at both iliac entrances. So we just deployed two 10 mm balloons. So this is where, since we had an aneurysm extension up to aortic bifurcation, so we could easily handle the expansion of both iliac extensions. The aneurysm was stopping before aortic bifurcation. That is when you have to go a little bit aggressively and dilate. So sometimes you can even create a rupture of aorta. So that's when you have to rule out endoleak before going for aggressive balloon dilatation. So this is a final angiogram showing good result, and we checked both iliacs for any dissection post balloon dilatation. So there was nothing, and then we pulled out both sheets followed by closure of the axis. Right, though we placed two proglides, we used only one as bleeding stopped with one proglide, so we didn't use second, because even the femoral artery size was only around 6 millimeters. So using two proglides can cause stenosis. So that was about the case. Thank you. How to start? Now connected.